All right, so if you're a psychiatry resident, you are absolutely going to work with patients struggling with alcohol use disorder. And one of the biggest resources they'll run into is Alcoholics Anonymous. The question is, how do we, as clinicians, actually understand it? So today, we're going to get into the evidence, the core ideas, and your specific role in using this really powerful community resource.
Here's how we're going to break it all down. First up, we'll define what AA is from a clinical point of view. Then, we're going to unpack its 12-step philosophy and the therapeutic tools it uses. After that, we'll look at the actual clinical evidence and, most importantly, we'll wrap up with your practical role in connecting patients with AA.
Okay, let's start with the absolute fundamentals. Before we can even talk about how it works, we need a really clear clinical definition of what Alcoholics Anonymous is.
So at its heart, AA is basically a mutual support fellowship. It runs on a disease model, which is huge. It views alcoholism not as some kind of moral failing, but as a chronic condition. So the goal isn't a cure like we might think of it, but getting the disease arrested through total abstinence, which means it requires lifelong management.
Now, let's get into the engine of AA's recovery program, the famous 12 steps. This is the structured path that really guides a member's journey.
Everything, and I mean everything, starts right here with step 1. From a clinical perspective, this is the moment. Admitting powerlessness is where the denial that we see so often finally gets confronted. It's the foundation for the whole model of surrender and acceptance, and it really marks the shift toward being ready for change.
This whole path is designed to guide members through a pretty profound personal transformation. You start by admitting you have no control. Then you find a higher power. And it's really important to know this is personally defined. It can be totally non-religious. Then you make amends for past wrongs, and ultimately have this spiritual awakening that sort of compels you to carry the message of hope to others.
Okay, so what are the actual psychological tools that make this whole fellowship thing effective? Let's translate this into a clinical framework that makes sense to us.
AA gives people these simple but incredibly powerful cognitive and behavioral tools. The slogan, "Just for today," is brilliant. It breaks down the massive idea of lifelong sobriety into just one manageable 24-hour chunk. And the HALT mnemonic, that's just a fantastic piece of applied CBT, right? It helps members spot and manage common relapse triggers in the moment.
Now, here is where things get really fascinating. In psychiatry, we're always talking about insight, understanding yourself. AA, though, really focuses on outsight. It's this powerful kind of vicarious learning where members see their own struggles reflected in other people's stories. And that just smashes through the isolation and denial.
The group setting itself is just inherently therapeutic. Identifying with peers keeps you from getting complacent. Anonymity creates this unique space where you can be radically honest without any social or professional fallout. And this is huge. Peer relationships provide a natural correction for transference. The group just isn't going to accept the same projections that a therapist might.
All right, as clinicians, we are driven by data. We have to ask, does this stuff actually work? So let's turn to the evidence and see what the big landmark research has to say.
Okay, first, a really key distinction. The big clinical trials didn't study AA directly. That's kind of hard to do. What they studied was something called 12-step facilitation, or TSF. This is a professional therapy model specifically designed to actively connect patients with groups like AA. It's the clinical application that we can actually measure.
So the results from the huge Project Match study were really telling. TSF was just as effective overall as our gold standard therapies, CBT and motivational enhancement therapy. And what's more, the data suggested that TSF might even have a slight edge for certain groups, like patients with lower psychiatric severity or people whose social circles are, full of other drinkers.
So, this all brings us to the most important point. What is our role? How do we bridge the gap between our clinic and this incredible community resource? Let's dig into the practical, actionable things we can actually do. So let's get into the nitty-gritty. What are the specific actions we can take in our day-to-day practice?
These 4 actions are absolutely key. 1. Facilitate a warm handoff. Don't just give them a pamphlet, connect your patient directly with an experienced member. 2. Get informed. Go to an open meeting yourself. 3. Be proactive and clarify that AA does not have a formal policy against prescribed psychiatric meds. That's a huge myth. And finally, number 4, just make it standard practice. Offer an AA contact to any patient who has impaired control over their drinking.
And hey, we have to remember the family system, right? Alcoholism is a family disease. It affects everyone. Al-Anon is a critical, parallel resource that provides support specifically for the adults, the partners, the parents, the friends in a patient's life.
And for the younger folks in the family, there's Alateen. It gives them a safe, supportive, and age-appropriate space to navigate the incredibly confusing and often painful world of having a loved one with alcoholism.
And here's why this all matters from a clinical standpoint. The research is totally clear. Positive family cohesion is a powerful predictor of better patient outcomes. So engaging the family with resources like Al-Anon and Alateen isn't just a nice thing to do, it's an evidence-based part of providing comprehensive care.
You know, maybe the best way to think about AA is to reframe it completely. It isn't an acute, one-and-done intervention. It's really a framework for chronic disease management, just like the long-term support systems we use for conditions like diabetes or asthma. It provides a sustainable, lifelong structure for maintenance and recovery.
So I'll just leave you with this question to think about in your own practice. In a field that focuses so heavily on the biological and the psychological, how might embracing the social and spiritual sides of recovery, which AA does so well, help you build more holistic and ultimately more effective care plans for your patients?